So I am so thrilled to introduce our speaker today, Dr. Lo Sicco, who is a dermatologist from NYU Langone. Her presentation is Hair Loss in Women, More Than What the Eye Can See. Give a little bit of background. Dr. Lo Sicco will address cultural competency for women with hair loss, associated psychosocial burden, as well as the common causes of hair loss. Dr. Lo Sicco is a board certified in dermatology and fellowship trained in complex medical dermatology with a clinical focus on hair and scalp disorders. It was during her dermatology residency that she discovered the need for more dermatologists who specialize in alopecia and the importance of giving a voice to the population of people who feel disregarded. She quickly realized the significant impact alopecia has on a person's confidence and overall quality of life. She recognizes the importance of individuality when it comes to the effect a diagnosis has on someone, as well as the response to treatment. At NYU Langone, she works with an incredible group of people to conduct clinical research and novel therapeutic trials with a focus on alopecia. Together, they strive to ultimately broaden our understanding of hair loss in addition to providing new therapies used to treat them. We are so lucky to have you. I'm going to turn it over.
Wonderful. Thank you, Jillian, for that wonderful introduction. And most importantly, thank you for inviting me today. It's an honor to be here and to speak to all of you about something that I'm truly passionate about. And I hope that that passion shines through during our presentation today. So today we're going to talk about alopecia or hair loss specifically in women and how it impacts our community. These are my disclosures. I have been an investigator for Regen Lab, who manufactures platelet-rich plasma kits, and I'm a current investigator for Pfizer. And we will be talking about some off-label indications, meaning they're used to treat hair loss, but not necessarily having an FDA approval for that indication or diagnosis. These are our learning objectives. After we're done with our lecture today, I would really hope that we can recognize and appreciate alopecia as more than a cosmetic issue, recognize the importance of cultural competency, which I also help to teach other clinicians as well, specific to alopecia. Identify easy ways to prepare for your hair loss visit. Recognize that many dermatologists are at a bit of a disadvantage at baseline when it comes to managing alopecia, because the average dermatologist in the country gets less than 30 minutes. Honestly, most of them get 15 to 20 minutes for a new patient visit. And you can imagine that's just not enough time to get everything in terms of the journey that has brought you to this point in time, as well as go through a clinical exam and going through benefits and potential side effects of medications to choose from, right? So oftentimes I see people who have seen multiple other providers having left feeling a little bit discouraged, like they were rushed. But the system is set up such that people aren't really given the luxury of time. So hopefully we can talk about some easy ways to prepare for your whole hair loss visit to make it as effective as possible at your first go around. Realizing that we don't have the luxury of time oftentimes when dermatologists in their outpatient clinics. And we want to identify various causes of alopecia or hair loss in women and identify ways that we can all be advocates, right? Not only for ourselves, but for the alopecia community at large. We'll talk about some actual testimonials that I've had from patients coming to see me in clinic, both pre and post treatment or pre and post visit. Testimonials, cultural sensitivity and competency, the psychosocial impact of hair loss, as well as tips to prepare for and use during a successful hair loss visit, hopefully. We'll talk about some clinical scenarios to teach us about the various types of alopecia, or a few examples of that, as well as advocacy. So these are actual testimonials of people that have come to see me in clinic. I hear them often. I feel so vain for coming in for hair loss, and I immediately dispel this. It is not a vanity issue, and I think that can be a misconception, not only by a community, but by people themselves, right? Oftentimes feeling guilty for coming in for a consultation, that they could always have it worse. But I really do my best to try to not minimize someone when they're coming in, right? Because it isn't a vanity. And Jillian said this too when she introduced me. Hair really is truly what helps us to identify as ourselves. And so part of my job as a hair loss expert is to give you that sense of self back, right? And it's also to give a sense of control, right? No one who has alopecia has asked for that. And so it's something that's been taken from us without our permission. And so part of my job is to give that to give that back to people. You know, we know that sometimes family members, friends, potentially even other clinicians might potentially disregard somebody or minimize what they've been going through. You know, my doctor told me that my hair loss is age-related and nothing can be done about it. Which is not true, right? There are certain types of hair loss in women that increase in prevalence as we age, specifically androgenetic alopecia, but there are certainly several things that we can do to manage that over time. So I really set the example that all is not lost. There really should always be something that we can do, right? But I always say, this is a marathon, not a sprint. It hasn't taken us overnight to get here, so give us some time. And while I always want to go back to when we were 21 years old. You know, I always say, even if we can't get back to when we were 21, I want you to feel like your best self when you look in the mirror. That's what's most important here. And then, you know, our last one, my doctor told me that I shouldn't worry about my hair and to be grateful that I don't have cancer. I think that's an example of minimizing someone who's coming in for hair loss, right? I really do my best to not minimize what anybody is going through. You know, obviously things could always be worse, but it's not about comparing ourselves to other people. It's about what our journey is, right? And what we're going through as any individual person. Okay, here are some testimonials at the end of the visit. Thank you for taking me seriously and not minimizing my hair loss. They told me I was imagining my hair loss. Thank you for validating my thoughts and feelings. Thank you for taking extra time to explain hair loss to me. Thank you for being my advocate. So these are really general themes, right? Feeling not minimized, feeling validated, and feeling like you're being advocated for, right? That somebody is in your corner. And so these are women who have covered their hair for personal or religious reasons. And so whether that's a gele, a shidal, a hijab, it doesn't matter if a woman has chosen to cover her hair or not. It doesn't mean that her hair is not important to her. And so I hear this quite often of women who have chosen to cover their hair for personal or religious reasons, saying that others have told them, why should you care about your hair? No one's going to see it anyway. And that really isn't true. One, if anyone is choosing to cover their hair in public, it doesn't mean that their family members won't see their hair when they're at home. Or most importantly, themselves when they look in the mirror, right? So that's what matters most. So remember, we all know this, right? Hair is personal and important to one's sense of self. And so I help to review this with clinicians as well. Sit down, right? When you're seeing people who are coming in with hair loss, there are studies to show that when clinicians sit down, it gives people the impression that you're spending more time with them, even if you're actually spending the same amount of time. And it really helps to create that sense of trust that you're not only emotionally, but physically on the same level with someone, right? In sitting side by side with them to show them that you're a partner with them, right? To help them get through this. We also want to educate the community as well as clinicians that hairstyling practices differ greatly between every individual person, right? And that can be a personal choice. It could be cultural. It could be because of a certain hair type, straighter hair versus curlier hair. So it's important that we know what these variations are. So, right, we can help to increase our competency culturally and have more empathy. There are certain types of hair loss that are more prominent in certain patient populations. So for example, somebody who might be skin of color might have curlier hair. So we call that a tighter curl pattern or tightly coiled hair. They might be at higher risk for certain types of alopecia, specifically traction alopecia, because of tighter hair tension styles that can pull tension not just along the frontal hairline, but sometimes in the back as well. You don't have to have your hair in cornrows to have increased risk of traction alopecia. Studies have been done showing that that women who practice ballet might be at increased risk for traction alopecia. Women in the armed forces might be at increased risk of alopecia because of the tightly pulled back hair in buns as well, right? So you don't have to have your hair in cornrow braids in order to have an increased risk of traction alopecia. meaning that higher tension is pulled along that hair for a longer period of time. And so it's important that we as clinicians are asking more so just about what hairstyling practice do you have, right? Do you use any chemical relaxers? Do you use keratin treatments to have hair straightening? Do you have perms, right, which are similar to breaking the protein bond of hair and then putting it back together to make a straight hair curly? We know that dyeing the hair or chemically relaxing the hair or perming the hair can potentially put the hair at more vulnerability for breakage, right? And if we're also putting that hair that's been treated into higher tension styles, that can potentially compound the risk of hair breakage or certain types of alopecia like the traction alopecia. So what are some early signs that we're pulling our hair too tight? Right? This was a study by Dr. Mayo out of University of Alabama in Birmingham. And she showed that pustules or pus bumps along the frontal hairline can be an early sign of traction alopecia, right? It's a warning sign that our scalp is yelling out for help to say, hey, you're pulling the hair too tight, right? That could be driving inflammation, so it's time to loosen it up. And you can see that the title of her article is It's Too Tight, Loosen Up and Let Your Hair Down, right? So it's important to recognize what are early warning signs that there could be alopecia looming. Okay, so remember, so I teach clinicians, right, to have cultural competency depending on straighter hair versus curlier hair. We know that if we have curly hair, it's a little bit more prone to breakage. That also includes when we're combing or brushing. It takes a more considerable amount of force to brush out curlier hair compared to straight hair. And so I hope to promote competency and empathy amongst clinicians to say, use your clean hand or a long cotton swab to part the hair in order to examine the scalp, and really try not to use a brush or any rough combing out, because of course, if someone with curlier hair is coming in to see you for hair loss, they might leave even more upset if you do this to their hair. And the girls, we can see their pre and post combing on the left versus the right hand side, right? And so it's important to practice that competency in clinic as well. So closing educational gaps. This was a study done by Dr. Kristen Lo, who is one of the hair experts out of Johns Hopkins. And I was very fortunate to be asked to collaborate with her for this project. And this project was us quizzing the knowledge amongst board certified dermatologists and their knowledge of hairstyling practices amongst patients. And what we found was that Black providers were actually more confident in both the knowledge and counseling of all hair practices. So that meant practices that were more prominent amongst people who had curlier hair or tighter coiled hair, in addition to patients who had straighter hair. Black providers are also more comfortable providing counseling on hair practices that are with patients that are a discordant hair type, meaning if the provider has more curlier or tighter curl-patterned hair, they were more comfortable also counseling patients who had straighter hair. And we saw that over 63% of providers reported the majority of their knowledge on hair practices were actually for personal experience. And only about 13% of those dermatologists had knowledge that came almost exclusively from their dermatologic training. And so what does that show? That shows that there's an educational gap within our teaching. And so the result of studies like this have led us to go back to our own teaching curriculums within dermatology to note that we need to close this gap, right? To teach hair practices and types of hair loss that might be more prominent based on the curliness of hair in dermatology residency teaching, such that when every dermatologist graduates from their residency program, they're well equipped to be able to treat people with curlier and straight hair. Okay, these are screenshots of multiple studies that show that people who have hair loss or alopecia have a significant psychosocial burden. They're at increased risk for anxiety, potentially depression, social withdrawal, potentially time lost from school or work, right? And we know that it impacts quality of life negatively. And so we're here to try to remedy that. Here are some tips for a productive hair loss visit. Like we said, most dermatologists in the United States don't always have the luxury of time. So how can we help to get the most out of a hair loss visit? I encourage clinicians to try to have a questionnaire before people come in for their first visit to try to save some time, because we know that it can take time, that many people have been struggling with hair loss for months to even years potentially, right? So we know that it can take a significant amount of time to get through that history. And doing a questionnaire that can help to have those questions answered beforehand for the clinician to review might help to save you some more time, such that you can take that time to focus on your clinical exam as well as the counseling to go over the medication options. Try to avoid washing your hair about 24 hours before your visit. Why? Because most dermatologists will do something called a hair pull test, and we're going to go review this. And that exam can help to tell us how active your shedding process is, if indeed diffuse hair shedding is part of the overall process, or overall problem rather, that you're experiencing. I ask people to avoid applying any products to your scalp, right? Camouflaging agents or fibers, as well as oils. Why? Because it can make it a little bit more difficult for the dermatologist to do their clinical exam. And oils specifically can sometimes mask flaking or what we call scaling on the scalp, whether that's in between the hair follicles or around the hair follicles. So sometimes it can mask a very important feature on the clinical exam as well. Why no biotin for around 3 days? So there are no studies to show that biotin is a treatment for androgenetic alopecia or telogen effluvium, which are really the two most common causes of hair loss in women. And indeed, we're going to go over a little bit longer about why we say for 3 days no, and why we might potentially want to shelf the biotin to focus on some other things that might have some more evidence-based medicine. Now, I will say there are some dermatologists that might not agree with this, but this is my take on it based upon what I feel the evidence shows so far. This is an example of why not applying the camouflaging fibers can actually make for a more productive visit. This is the middle of the scalp with some camouflaging fibers, right? And we can see that's the middle part. This is after a little alcohol swab was used to remove those camouflaging fibers. Those camouflaging fibers are meant to be sticky so that they're not flying off of your head when you're walking down the street, right? But you can see that they can be somewhat difficult to remove. So coming with nothing on your scalp can really help to give the dermatologist the advantage when doing your clinical exam. Okay, why no biotin prior to the initial visit? So to circle back, like I said, there really is no clinical trial data to demonstrate efficacy of biotin for the treatment of alopecia. And in 2017, the FDA released a warning that many dietary supplements that are promoted for hair, skin, and nail benefits contain hundreds of times more than the recommended daily intake of biotin, which is about 0.03 milligrams. Why is that relevant? It's not that biotin is dangerous. Biotin is a water-soluble vitamin, so you would just pee the rest out that your body didn't need. But this is relevant because biotin can interfere with certain blood tests. Most commonly, it's the thyroid blood tests. When the thyroid is not functioning normally, that can lead to a common cause of hair loss called telogen effluvium. And so it's very important that when your doctor checks your blood work, it's reliable. So the screenshot in the center was a study that was done by the endocrinology group at NYU. We know that the thyroid stimulating hormone, or TSH, may be falsely low with high dose biotin use, right? So that can complicate somebody's clinical picture and can be very confusing. And this report here was reports of Graves' disease that was misdiagnosed, toxic nodular goiter that was misdiagnosed, or even a case of stable Hashimoto's thyroiditis that was mistaken for progression to Graves' disease, right? So it's really important that when we take blood tests, they're reliable and not leading us down a potentially incorrect path. Fortunately, the assays for troponin are being worked on. What is troponin? Troponin is an important blood test if you were ever to go to the emergency room with chest pain. It's a blood test that's used to check for acute myocardial infarction or heart attacks. And when the troponin is elevated, that can be relevant. Troponin may be falsely low with high biotin use. And so fortunately, they're working on assays to limit the interaction with biotin with the troponin, but it's very important, right? Because of course, for safety reasons, we don't want to be on anything that could potentially lower a very important blood test that's important for safety. Okay, so we're going to circle back to our hair pull exam test. And so this is a test that's done to determine the severity and location of the hair loss. Your dermatologist will clinch about between their index finger and the thumb, about 50 to 60 hairs, starting very close to the scalp and pulling firmly but gently away from the scalp and along the hair shafts. We typically perform this exam in multiple regions of the scalp to get the best indication of the active shedding. And this is why it's most relevant to not shampoo or wash the hair and scalp for 24 hours before. So this test is most relevant because if you're washing the hair, if you're washing your hair the day of your exam and definitely combing it, anything that would have come out in the shower or in your comb that morning is not going to come out in the dermatologist's hand, right? So it makes that pull test a little bit less reliable. And a positive pull test is defined as 5 or more hairs, indicating that the hair loss still has ongoing activity, right? So it's a very simple yet very useful clinical tool that we can use in practice. What is a hair card test? The hair card test gives us is very simple. I use an index card in my clinical practice. And most commonly, I'll put it up against the middle part. And we can see that's the middle part of someone's scalp and their hair right up against that index card. And what can we see? This can help to give us an indication if hairs are tapered or pointy haired, which can signify regrowth. It can give us an indication if the hair is breaking, because a blonde-ended hair or a broken hair will look almost the same as a scissor cut hair, right? If it's cut from side to side or if it's breaking, right? So it can give us an indication if there's a hair fragility problem, if it's breaking off. It can also help to give people reassurance if hair is coming out. If we can see evidence of regrowth, that's a wonderful thing. It can help to provide some reassurance, right? If hair is coming out, we also want to see, is there evidence of hair coming back or regrowth as well? And with the naked eye, sometimes it's easy to tell if there's some variation in the caliber, which is the thickness from side to side of the hair shaft, right? If some are thinner as well as thicker, right? And if there's a lot of variation, that can be an indication that androgenetic alopecia, right, or female pattern thinning or baldness could potentially be what's driving the hair loss or thinning over time. So trichoscopy. Trichoscopy has gotten very popular over the last decade because it's a very useful clinical exam maneuver that we can use as dermatologists. So most of you, if you've been to your dermatologist for a yearly skin check, if you haven't been, it's time to go. And you'll oftentimes see your dermatologist pulling out this contraption called a dermatoscope. This is a polarized handheld microscope that oftentimes is 10x in magnification or greater that will allow us to see things that we might not be able to have seen with the naked eye. And it can be very useful for us to have an indication, potentially even without doing a biopsy on the scalp, to help to point us in the right direction of what could be causing the hair loss. This one is another reason of why not using the oils on the scalp is beneficial, because remember, that could potentially mask any of the flaking or scaling that can be an important part of the clinical exam as well. Patient education. We all know that patient education is ineffective if we as the patients fail to understand what is communicated to us, right? There were studies done in the emergency room or the emergency department showing that the 20% of patients reported comprehension difficulties in this study, and 78% of patients demonstrated a comprehension deficiency at least one domain of their visit, right? That can be an educational gap, right? Because communication is very important as well as comprehension of the information that is given to us when we're in clinic. Another study found that patients retain about 50% of information that's given by their healthcare providers, and potentially about 50% of that information was actually remembered correctly. What are some additional barriers to information retention? Anxiety and stress. So if we already know as patients, we might be at lower likelihood of remembering information correctly. We know that anxiety and stress, that can be an additional barrier when we suffer from alopecia, can be additional barrier to retaining information, right? During our clinical visit. So what did we do? I think that's one of my most passionate things about being in academic medicine is helping is when we identify a gap in research, we really do our best to try to fulfill that gap. And so we had over the course of a year, we produced a series of multiple educational videos that we have available online, and we're going to watch one shortly. And we made them publicly available such that not only do we use them, I use them very regularly in my clinical practice, but we wanted them to be available so that patients, as well as other dermatologists and clinicians, can refer back to them to help to educate their patients as well. Because we understood, like we saw from those studies, education can be a barrier if we're already stressed, right? And we know that many patients who suffer from alopecia also suffer from stress and anxiety as well. And so our study, we wanted to see how useful was our video library in helping to educate patients and how well did they retain information. And so we enrolled 100 patients, 90 of whom participated in our study, and we randomly assigned them to watch one of 3 videos. One that was on the hair cycle that we're going to see shortly, one on platelet-rich plasma injections, and the other one on topical minoxidil application. And so while we tried to model other studies. So we showed them the video, and shortly thereafter, we gave them a quiz. They did a quiz before watching the videos and a quiz after watching the videos. And we wanted to see how well did they score after watching the quiz. And interestingly, 11 of our participants had already seen one of the videos prior to the study. And their pre-test video scores were significantly higher than the pre-test video scores of people who had never seen the videos before. Why is that important? That shows that there might be some long-term retention of material, right? That giving audio and visual cues, especially being able to refer back to it, can help to retain information long-term, right? So it's another useful educational tool that we can use in practice. Fortunately, in our study, we showed that there were gains observed in knowledge on all of the topics. There was a significant increase in our participants' cumulative survey scores after taking the quiz versus taking the quiz before they had seen our educational videos. So we showed that they were very beneficial in terms of education. And again, like we said, for those 11 participants who had already seen the videos, potentially showing that there was long-term retention of the material. And most importantly, 87% of our respondents described the videos as helpful. Of course, if it's not helpful, people aren't going to refer back to it. And I was also very pleasantly, not surprised, but I was very grateful to show that 74% of people indicated that they would share the video with a friend who wanted to learn more about hair loss, that they felt it was useful enough to want to share that knowledge with other people as well. Right, we know that the community, the alopecia community at large is incredible. It's an incredible resource for people, and we really help to advocate and protect each other, right? And part of that is also sharing knowledge. Okay, so we're going to watch one of our educational videos.
The hair follicle has a reoccurring life cycle consisting of 3 stages: anagen, catagen, and telogen. You have hairs in all 3 stages at any given time. The average person naturally loses about 100 hairs per day. Anagen is the growth phase of hair, lasting about 3 to 5 years. The longer hair is in anagen, the longer hair will grow. About 85% of hairs are in this stage. Catagen is a transition phase of the hair cycle, when the hair reaches maximum growth. The mature follicle loses its blood supply over the course of about 10 days, just like a beautiful rose. Red and full of life, will inevitably waste away. Telogen, the resting phase, lasts up to about 3 months and occurs when hair naturally sheds. Approximately 10 to 15% of hairs are in this stage at any given time. Sometimes, a larger portion of hair may prematurely switch from anagen to telogen, resulting in large amounts of hair shedding. This condition is called telogen effluvium and can be triggered in several scenarios, most commonly presenting 3 to 6 months after a significantly stressful event, medical illness or surgery, starting or stopping a new medication, or after giving birth.
Okay, so we really, hair can be complicated, right? And we want everyone to know what is normal so we know what abnormal is, right? And so that's why we produce the hair cycle video, because the hair cycle can be complicated, let alone, trying to explain that in addition to everything else in a clinical visit. And so oftentimes I use this video in clinical practice as a helpful educational tool, also to promote long-term retention. And you can see that I've put the handle for Instagram at the bottom there. It's at NYU Langone Hair. But do not fret if you do not have an Instagram account. These videos are also live on the NYU Langone YouTube account. So if you go into Google and you type in NYU Langone Health YouTube hair, this video library should pop up, and you can choose from any of the hair videos that we have live. Okay, so now we're going to go through a few clinical scenarios so that we can highlight some types of hair loss in women. So we have a 36-year-old woman who was otherwise healthy with diffuse hair thinning that developed over several weeks. She doesn't have any scalp symptoms. Her hair pull test was positive. Remember, that means excess amount of hair shedding. She denies taking any new medications or any other external stressors. And we can see that picture in the center is what our dermatologist sees when they look underneath, when they look in that handheld microscope, that dermatoscope at the scalp. Now, this patient has alopecia areata. The diffuse type of alopecia areata is actually quite uncommon, but I put this in here to actually reflect that there are a fair number of findings when we take a look at the scalp with that dermatoscope that can help to point us in the right direction, even without doing a biopsy on the scalp. And it can help the dermatologist determine not only the diagnosis of alopecia areata, but also if the inflammation is active versus less active, right? And so there are certain buzzwords that we use, like exclamation point hairs or black dots, that we use as buzzwords in dermatology to denote active inflammation in the setting of alopecia areata. And this is some helpful tips. I like to explain why something is the way that it is so that we can promote long-term retention of material. If you've heard of the term exclamation point hair, why is it called an exclamation point? Well, if we look on the far left, or right, depending on how we're looking at the screen, we see the column that says exclamation point hairs. Take a look at that photo underneath. If you look at the very top of that hair, you can see that it looks thicker than very close to the scalp there at the bottom of that photograph. And it looks tapered or thinner at the bottom than it does at the top. The top portion of that hair follicle is actually the normal thickness of the hair shaft. It's thinner at the base as a result of the active inflammation from the alopecia areata. And so the inflammation from the alopecia areata causes abrupt cessation or stopping of the hair shaft formation, and that hair shaft is thinner in caliber or thickness from side to side. And that's why it's called exclamation point, because it's thinner at the bottom or the base and thicker at the top, but the thicker is actually the normal, right? And that's why it's called exclamation point hair. A black dot is called a black dot because it literally looks like a black dot, like we see in that photograph. But what does that mean? That black dot is actually an aerial shot of the top of the hair shaft as it's breaking out as it's coming out of the scalp. Why is it breaking? Because the inflammation is causing fragility of the hair shaft itself. And that hair shaft is fractured at the level of the skin surface. And as we can see, those black dots, as well as those exclamation point hairs, give us a clinical clue as your dermatologist, noting that the alopecia areata is active. And it's also very helpful to show, to point toward the diagnosis of alopecia areata. Now, if we look at the far end, the little pigtail hair, if we can look closely to those yellow arrows are pointing toward what we like to use buzzwords in dermatology of pigtail hair. If we've seen a pigtail, it's looks like a little curly Q, their tails. Well, these hairs are called pigtail hairs because they look very similar. They look like little curly Qs. That's a sign of regrowth in the setting of alopecia areata. And circling back to our patient scenario, yellow dots that were not something that we reviewed, but was in our table that can denote inflammation activity, as well as the pigtail hair that's in the purple circle, right? That's a clinical clue to the dermatologist to show that alopecia areata could be the cause of the hair loss. And remember, the pull test can be done all over the scalp, but if somebody comes in with the most common cause of alopecia areata, which is patch type, these circular coin-shaped patches of alopecia most commonly on the scalp, but can potentially occur in other parts of the body, your dermatologist can also do a hair pull test adjacent to those patches as well as diffusely all over the scalp to check for activity. Here's a next clinical scenario of a 50-year-old woman who presents complaining of intense scalp burning for 6 months. Your dermatologist performs a global exam, and the card test that we talked about at the vertex are closer to the crown of the scalp. And there we can see the card test at the bottom, as well as near the crown of the scalp, the global photograph above. What is our diagnosis here? It's CCCA, or central centrifugal cicatricial alopecia. Now, what is this type of hair loss? This type of hair loss is a scarring or potentially irreversible type of hair loss that does disproportionately impact patients of color, specifically more commonly in Black women. More recently, we have discovered that there is a genetic predisposition to this condition and that there are certain medications that can work better for this as what we call a fibroproliferative process. Refer back to Dr. Crystal Agu's study in identifying the knowledge gaps. She's also instrumental in doing a lot of the CCCA research as well to help to push the needle forward in terms of cause of the CCCA or risk factors, as well as treatments as well. This study was done by Dr. Callender, showing that by using the card test and looking near the crown of the scalp and finding the broken hairs on the card test exam can be a very helpful clue for us that the CCCA could be going on early and evolving over time. So remember, it's very important if someone has a scarring or potentially irreversible type of hair loss that we can catch it as well as intervene earlier on to give people the best chance of success. Our next clinical scenario is a 50-year-old woman who presents with diffuse alopecia areata. Her hair loss has caused withdrawal from social and work activities. What is the next best step in our management? And we can all answer this one. The answer here is writing a letter of medical necessity for insurance wig coverage, as it is likely to improve her social anxiety. So why did I put this clinical scenario in here? It's really to help us be advocates, right, as your clinical providers. But I'm also going to review about how we can be advocates for each other in the alopecia community as well. So we know that wigs can be very expensive. Number one, we know that they're very important toward increasing quality of life in various types of alopecia. We know that, right? Including alopecia areata, the androgenetic alopecia, that is, women can be more prominent as we age, as well as chemotherapy-induced alopecia. They can range in price from less to $100 to thousands of dollars. Right, and typically the ones that are thousands of dollars are made with real human hair compared to the cheaper wigs that can be with synthetic hair. And we know that a wig can look more realistic versus less realistic. And the last thing somebody wants with alopecia when they want to cover their scalp with a wig is to have a wig that is more clearly a wig than not, right? Because nobody wants to be asked unsolicited questions, what is wrong with you? And I hear that all too often. Right? And so we believe that everybody really should have equal access to wig coverage, and we're going to talk about that shortly. Okay, our next clinical scenario is a 53-year-old woman who presents with diffuse hair loss 1 month after treatment with paclitaxel and carboplatin, which is relevant for our breast cancer survivors. She asks you if there is anything that could have been done to help to prevent hair loss. And we can see the pre-chemotherapy versus the post-chemotherapy picture. Now, while many women who experience hair loss when they have chemotherapy in the setting of treating the breast cancer can have regrowth, we know that there are scenarios where the regrowth is not 100% of what it was before. And so is that from the chemotherapy? Has the chemotherapy unmasked Something else that was going on, a clinical scenario that's very common in my practice, is when the excess hair shedding has occurred, it can unmask another type of alopecia called androgenetic alopecia. So fortunately, chemotherapy-induced alopecia, as well as androgenetic alopecia, very common cause of alopecia as we age as women, can both be treated with a medicine called oral spironolactone. There's also another type of medication that we're going to get to shortly called low-dose minoxidil. And it's made famous through the New York Times article, but it technically has been around for several decades, and we're going to get to that in a little bit. But first, let's talk about our patient scenario. So which of the following statements is true? Here, the answer is both A and C. So patients treated for breast cancer may consider refusing treatment altogether due to significant distress over hair loss. And a lot of clinicians don't realize this actually. And C, scalp cooling may be utilized to prevent chemotherapy-induced alopecia. And so, as dermatologists, as well as oncologists, can be our patient's best advocate, right? Because if somebody doesn't know that a treatment is potentially available for them and can be effective in helping to prevent hair loss in their setting of the chemotherapy, they won't know that it's a treatment option to be able to utilize in the first place, right? And so we know that scalp cooling can be used to help to prevent chemotherapy-induced alopecia. The most data that we have in terms of the safety data, as well as the efficacy, in being effective in treating the chemotherapy-induced alopecia, is in the setting of breast cancer treatment. And we know that hair loss may be most difficult chemotherapy side effect for breast cancer patients to cope with. And we know that, and this was a study done out of England that showed that over 8%, that is not small, 8% of patients admitted to considering refusing cancer treatment altogether due to significant associated distress over the prospect of hair loss. So it needs to be taken seriously, and we need to advocate as oncology doctors as well as dermatologists to know that this is a safe and effective treatment for our patients who are choosing to undergo chemotherapy to treat breast cancer. And so this quote was taken out of the article that I have at the bottom of the screen here, and it reads, hair loss worries me because it would be an outward sign of my incapacity, and this is upsetting when one is trying to be normal, even with cancer. How can we advocate? So believe it or not, every individual person on this call today can be an advocate for ourselves as well as the alopecia community at large. I partnered with several people who are in this photograph in this montage, which reads, wigs should be a choice because alopecia isn't, support HR 5430. So how can we help? We created the Alopecia Justice League, which is a social media advocacy league that we started. Myself, Allison, Lindsay, and Julie, and we are also members of the Alopecia Areata support group at NYU, supported through the National Alopecia Areata Foundation. And our job as the Alopecia Justice League is to spread awareness of HR 5430 that we'll talk about in more detail. And if it were passed, it would mandate Medicare to cover wigs as cranial prosthesis for any type of alopecia with a letter of medical necessity from your clinician. And so if you feel strongly, check out Alopecia Justice League on Instagram, but please, please consider reaching out to your local representative, and we'll talk about how you can do that shortly. How can we help, right? So go on Google, go to congress.gov. If you type in your zip code, you can find out, if you don't already know, who your local representative is. And you can either call the office, or many of them have online forms that you could submit, or simply send an email advocating for HR 5430. So unfortunately right now, this bill has a lower likelihood of being passed because we need more support and we need you. And so please consider writing to your local representative to advocate for HR 5430. As we said, this bill reclassifies cranial prosthetics, wigs, as durable medical equipment, and thus eligible for Medicare, and would assist patients with any type of medical hair loss. And if passed, we could have a letter of medical necessity written by an attending physician, a dermatologist, oncologist, right? as a medical necessity of such cranial prosthesis or wig as part of a proposed course of rehabilitation treatment, right? Utilizing wigs as much of the therapeutic plan as any other treatment would be, right? We're all worthy of treatment. Okay, let's get back a little bit to scalp cooling. So a previous study was done showing that 62% of oncologists believe that all patients should be educated on scalp cooling. However, interestingly, only 25% actually consistently initiated such conversations. And so we did a study and partnered with Taylor Novis, who's at Henry Ford Dermatology. And we showed in this study that when surveying over 80 board certified dermatologists, only 22% of the board certified dermatologists that we surveyed were very familiar with scalp cooling. So we identified a knowledge gap even amongst dermatologists. And this was a wonderful piece of data here. 76% of the dermatologists indicated a desire to learn more. So we know that dermatologists want to learn more in order to help their patients, right? And a minority of them actually had the knowledge that was of being very familiar with scalp cooling. And so we identified another educational gap that we can help to fill by educating other dermatologists in the community. And so we know that studies show that scalp cooling can be very effective for preventing chemotherapy-induced alopecia, specifically in breast cancer patients. Although we also have other studies to show that it can be beneficial in using other types of chemotherapy for treating other types of cancers in the body as well. And so recent studies show that over 50% of patients with breast cancer maintained over 50% of their hair after treatment using scalp cooling machines. But there are some factors that can impact the efficacy, right, of how well the scalp cooling works, what chemotherapy type, the regimen, how many cycles, as well as the capper expertise, and we'll get into that in a second. So a capper is required, the two main types, and these are the two general categories of scalp cooling: manual scalp cooling or cold caps. Until more recently, the cold caps had to be rented, bought or rented, and can be quite costly. And they did require a capper to come in while the chemotherapy was ongoing, right? So while someone is sitting in the chair for hours on end getting their chemotherapy, they needed a capper. Was more oftentimes a family member, right? But sometimes there are clinics who do have nurses who do the capping. And oftentimes that cap needed to be changed quite frequently, right? Every 20 to 30 minutes before, during, and after the chemotherapy treatment. And so it can be cumbersome in terms of needing an extra person with you. It can be costly if not covered by insurance, and those can be challenges there with the manual scalp cooling. Scalp machine systems can be beneficial because it doesn't require a capper. It's a one-time cap fitting, and you can see there that it doesn't require somebody to continuously remove and replace the cap that's thawing, right? That it's a manual system. There are multiple companies. We do have the Paxman machine at NYU, and there are multiple scalp cooling systems within New York City. We're very fortunate to live and practice within New York City because we really do have access. There are multiple institutions that do have the scalp cooling machines available within their oncology units. But again, sometimes it can be a barrier if there's lack of insurance coverage as well. So another plug for Dr. Novis's nonprofit, it's called Cap and Conquer. Please check them out online as well as on Instagram for support as well as for utilizing their services, because Cap and Conquer was created by Taylor in order to provide scalp cooling for anybody independent of their ability to pay, because her goal was really to remove cost as a barrier to getting care. So check it out at Cap and Conquer, started by and run by Dr. Taylor Novis. So what are some treatments that have become more popular? Well, oral Minoxidil, which is the oral form of Rogaine, and that's the medication that was focused on recently in the New York Times article. The medication has actually been around for decades and has been used since the 1970s as a treatment for high blood pressure or hypertension. In the 1980s, oral minoxidil was compounded as a topical medication in clinical trials and eventually became an over-the-counter medication in the United States. And most commonly, it's used as 5% solution or foam as Rogaine or topical minoxidil store brand. That can be used once or twice a day. But more recently, in less than the last decade, low-dose oral minoxidil has been used really across the board to treat multiple types of alopecia. Why do we call it low-dose minoxidil? Well, when minoxidil was used at the higher doses, so higher than 5 milligrams in people with high blood pressure, they found that people had an increased risk of having fluid retention around the heart or lungs. If you go on Google, there's actually a black box warning for that. And so we really wanted to, as the dermatology community, Dr. Sinclair, who practiced out of Melbourne, Australia, had done a lot of the preliminary studies. And the question was, can we use this medication at lower doses, have it still be effective, but minimize the amount of side effects? And the answer is yes. And so that's where low dose minoxidil came into effect, when we're using it at 5 milligrams or lower. And we found that the side effects were much less when using it at low doses while still being effective in treating various types of alopecia, both scarring as well as non-scarring types of alopecia. The doses will range anywhere from less than 1 milligram to up to 5 milligrams. Now, of note, 5 milligrams is technically the lowest blood pressure dose of the medication. So everybody does this a little bit differently in their practice, but I do take blood pressures at baseline as well as each subsequent visit for my patients, because even though lightheadedness or syncope or passing out is lower risk, of course, it's not zero. And so safety first. I do a lot of counseling for my patients to say stay well hydrated, especially since a lot of my patients are already on the spironolactone, which is technically another blood pressure pill. And that medicine is also a water pill or a diuretic. So you want to stay well hydrated, because we know if you're dehydrated in general, that can drop your blood pressure independent of anything else. But fortunately, the lightheadedness is less than 2% and most commonly presents within the first week of starting the medication. But also be cognizant, right, that as we're increasing the dose, we reset the clock in terms of potentially the side effects occurring again. And so we found in our study that was done by the principal investigator, Dr. Sergio Baño Galvan, who's one of the hair experts who practices out of Madrid, Spain. And you can access this article likely online. It's published in the Journal of the American Academy of Dermatology. And he was responsible for running this study that Dr. Shapiro and I, who are the two hair experts at NYU, were co-investigators on. And really our question was, what were the most common side effects of our patients with various types of alopecia when taking this medication to treat their alopecia? And we found that in up to 15% of patients, 1-5, the most common side effect was hypertrichosis. And that means hair growth on the face or body. And that's really dose dependent. What does that mean? That means the higher the dose, the higher the likelihood, the lower the dose, the lower the likelihood. And I really have found that this is the most common reason for women to not go on the highest dose of the minoxidil to treat hair loss, which is 5 milligrams. Because if we get facial or body hair growth, that can be much more annoying to remove compared to some of the guys who might not be as bothered by facial or body hair growth. Another important point to remember that whether or not you're starting topical minoxidil or Rogaine or the oral minoxidil, sometimes you can go through an episode of excess hair shedding. Most commonly starts around 2 weeks after starting the medication, but most fortunately should resolve on its own within a few weeks. And so that should not be a permanent loss. And if occurs, represents a momentary setback for a much longer term gain being on this medicine. But I really tried to discuss this, even though it wasn't prominent in our study. I discussed this as a potential because you can imagine if you're seeing your provider for hair loss coming in with excess hair shedding, if your provider didn't talk about this as even a potential and you experienced it, you can imagine that sometimes you might lose trust if somebody didn't discuss something that was a possibility, if already you were, you were coming in with hair shedding issues. And so I really try to do my best to counsel people across the board regarding the possibility of some excess hair shedding when they start the medication, but also to give them reassurance. What are the less likely side effects, but also very important to discuss for safety reasons? Lower blood pressure, or termed hypotension. What can be signs of your blood pressure being low? Well, dizziness, right? And so that is more likely to occur, at least in our study, we showed within the first week of the medication, but I also note that, it can occur as you're increasing the dose over time as well. Peripheral edema, now what the heck is that? That's the fluid retention. Now, we didn't show in our study that there was fluid retention around the heart or lungs, but you can have fluid retention in general when you're taking the minoxidil at lower doses. More likely, gravity will take that fluid downward, and you'll have a little bit of ankle swelling. Less commonly, having some fluid retention around the waistline, noting that the belt's a little bit tighter, the pants feel a little bit tighter, and much less commonly in the face. Tachycardia, also lower than 2% risk, is the increase in heart rate. That can also occur with the topical form of the medication as well. And in our study, we showed that it was more likely to occur within the first day of starting the medication. And most importantly, we did not see any of that severe fluid retention around the heart or lungs that was described in taking it in higher doses in people who are being treated for blood pressure or high blood pressure. So what are some takeaway points? Hair loss is more than just a cosmetic concern. It causes a negative impact on quality of life for many. Cultural competency is important amongst our clinicians when diagnosing and treating hair loss in women. And for us as patients, preparing for a hair loss visit can be very important because remember, most dermatologists have less than 30 minutes with new patients. So we want to do our due diligence to help to have our hair loss visit initially be a success so everybody can feel like they got the most out of the visit. And remember that we can all be patients. So we can all be patient advocates rather, right? As well, advocates for ourselves as well as for the alopecia community at large. These are my references and my acknowledgements for our hair videos. And so we created this montage, and this was for our resident and fellow appreciation day at NYU. But I put this together because it reads, "We bear witness to individuals who prove that one person really can make a difference," because this is really relevant to all of us. It doesn't matter who you are, where you come from, everybody's voice matters. Thank you very much for your attention.